Assalamualaikum warahmatullahi wabarakatuh. Selamat sore para peserta. Selamat datang kembali dalam sesi Simposium Plenary ke-9 yang merupakan sesi terakhir dari Deksa Medika dengan tema New Drugs, New Hope for COVID-19 Critically Ill Patient. Diingatkan kembali kepada seluruh peserta bahwa di akhir acara akan ada pengundian door prize sekaligus closing ceremony. Baiklah, kami akan memanggil kembali moderator yang akan memimpin jalannya sesi Simposium Plenary ke-9. Kepada yang terhormat, Profesor Dr. Nancy Margarita Rehatta, SPA NKNA, KMN, kami persilahkan.
Thank you, Dr. Marisa. Good afternoon and salam to all the participants, and special for our guest from New York, Dr. Robert M. Grosberg. But I think it is maybe good morning for Dr. Robert, and also my colleagues, special colleagues from University of Indonesia, Prof. Menaldi Rasmin. In this session, we have two speakers. One is Professor Menaldi, and the second is Dr. Robert Grosberg. So we will start with Professor Menaldi. You have 25 minutes, Prof. And the question and answer will be done after the two speakers finish their presentation. The topic is a success rate of treatment of critical ill COVID patient by Avigan in Persahabatan Hospital, Jakarta, Indonesia. The time is yours, Professor Menaldi. 25 minutes.
Thank you and good afternoon to Professor Rita and also to the official and also to all the participants. To Professor Grosberg, good morning and please allow me to speak in Indonesia. Mohon host kalau boleh slide pertama. Tema memang adalah tentang new drugs, new hope for COVID-19 critically ill patient, dan pada saya ditanyakan tentang Avigan, tetapi harus saya sampaikan bahwa Avigan bukan obat yang secara rutin diberikan di Rumah Sakit Persahabatan. Di sini ada Dr. Nevi, spesialis anestesi, mungkin juga nanti bisa memberikan bantuan tambahan bagi keterangan-keterangan saya, dan saya akan mencoba melihat secara keseluruhan untuk membagi pengalaman ini saja kepada semua. Mohon slide berikut.
Slide-nya di panitia, Prof.
Iya, betul. Udah siap tadi katanya? Iya, oke, ini disclosure. Oke, selanjutnya, slide berikut. Ya, baik. COVID-19 adalah sebuah penyakit yang tiba-tiba saja datang ke seluruh dunia, makanya namanya sebagai pandemi, diakui sebagai pandemi oleh WHO, dan dimulai dari kota Wuhan. Pada waktu itu dikenal sebagai pneumonia Wuhan. Ketika banyak sekali orang masuk ke rumah sakit, masuk ICU, masuk ventilator, tanda-tandanya adalah pneumonia, meninggal, tapi itu terjadi berturutan begitu cepat. Sehingga semua kaget ada apa ini. Sementara dunia kita sudah terbuka sehingga pesawat hilir mudik masih berterbangan ke sana kemari, termasuk dari Wuhan, dan dari Wuhan ke beberapa daerah lain di Cina juga, Shanghai, Beijing, dari sana juga terbang juga ke tempat lain. Maka dengan segera penyakit ini menyebar dengan cepat ke seluruh dunia. Jadilah dia sebuah pandemi. Tidak kurang dari Indonesia sendiri ikut mengalami pandemi ini dan belum habis sampai sekarang, walaupun kita pertama kali menyatakannya 2 Maret 20, tapi sampai sekarang masih ada. Kemudian dicarilah penyebabnya. Di antaranya waktu itu, Prof. Rita pernah ingat barangkali, beberapa orang ditemukan tiba-tiba di tengah jalan pingsan. Bahkan ada yang meninggal jatuh di pinggir jalan. Dulu kita anggap itu berlebihan sekali dan ini dibuat-buat dan sebagainya. Sekarang kita kenal itu sebagai happy hypoxemia atau happy hypoxia. Dan ini menunjukkan bahwa memang pneumonia Wuhan itu bahaya betul begitu. Dalam perjalanannya diketahuilah bahwa sebetulnya penyakit ini disebabkan oleh sebuah virus yang dikenal baru disebut sebagai SARS-CoV-2 atau Severe Acute Respiratory Syndrome Corona Virus Type 2. Jadi ini adalah virus corona tapi tipe 2. Jadi dia tidak begitu sama dengan tipe-tipe yang sebelumnya. seperti yang sudah kita kenal pada kejadian Asian influenza, atau juga flu burung, avian flu, atau juga sebagai Ebola, juga sebagai MERS dan sebagainya. Ini adalah tipe 2 yang rupanya angka tularnya lebih tinggi dan kejadian perburukan yang disebabkannya lebih berat dan lebih cepat. Itu yang kita lihat sehingga angka kematian kita sempat tinggi sekali. Walaupun sekarang sudah agak turun, tetapi tetap saja angka kematian kita masih tinggi dan bahkan termasuk yang tertinggi dan di Asia adalah yang paling tinggi. Kita lihat si virus itu dia masuk ke dalam melalui reseptor yang dipercaya reseptor yang dimasuki adalah ACE2 dan itu banyak di saluran napas, belakangan ketemu juga di saluran cerna. Dan kita tahu bahwa virus SARS-CoV-2 ini adalah virus RNA yang semuanya diliputi oleh protein. Spike-nya atau tajinya adalah protein, membrannya protein, envelope-nya protein, RNA-nya sudah pasti protein. Jadi dengan kekuatan itulah dia masuk, dibantu oleh reseptor lain yaitu TMPRSS2, dia tembus dan masuk, dan di saluran napas yang saya mampu untuk bicaranya adalah pada sel pneumosit. Artinya di mana? Di ujung, di perifer, yaitu di bronchioles terminalis sampai ke alveol. Sudah di ujung sekali. Itu sebabnya kenapa pada saat pertama kita melihat gambar ceplok-ceplok secara radiografi adalah di bagian perifer. Slide berikut. Nah, begitu kita menerima pasien COVID, maka seringkali pada waktu awal dia jatuh ke dalam kondisi yang sangat berat dan kritis. Kita tahu COVID oleh WHO dibagi atas tanpa gejala, ringan, sedang, berat, dan kritis. Nah, umumnya pasien datang dalam keadaan berat dan kritis ke rumah sakit. Saya kira teman-teman di Perdatin pasti hafal benar dengan kondisi ini. Maka yang dipercaya pertama adalah ini pasti terjadi imunosupresi yang begitu berat. Sehingga pendekatan pertama adalah pada imunosupresinya. Itu sebetulnya sudah tepat. Untuk melihat adalah di titik mana kejadian yang membawa pasien itu. Apakah masih pra hyperinflammation, atau di titik yang sudah hyperinflammation. Kalau inflammation sudah pasti. Tapi apakah pra-hyperinflammation, ataukah sudah hyperinflammation, atau bahkan sudah sampai ke cytokine storm. Maka algoritma ini dipakai untuk menilai di titik mana dan apa intervensi yang harus dilakukan. Dan di kiri itu adalah beberapa pemeriksaan atau penanda atau marker yang biasanya dengan cepat diperiksa. Nah, ini yang kesulitan kita bahwa di Indonesia ini terlambat sekali bahwa kita bisa memeriksa selengkap-lengkap itu. Biasanya dulu kita baru sampai di tahap darah lengkap, dan mungkin tambah sedikit yang lain seperti fungsi hati dan sebagainya. Slide berikut. Nah, kita masuk ke klasifikasi atau kualifikasi derajat berat dari COVID-19 oleh WHO yang disebut sebagai ringan, sedang, berat, dan kritis. Ya. Nah, yang berbahaya sebetulnya yang dua. Ada dua titik yang bahaya, yaitu orang tanpa gejala atau asymptomatic. Padahal dia confirm. Orang ini berbahaya bagi komunitas, bagi masyarakat. Karena dia tidak merasa punya gejala, maka dia tidak merasa sakit, maka dia juga abai dengan APD-nya, dia taruhlah di bawah hidungnya itu maskernya, atau bahkan di bawah dagunya itu maskernya itu, dia juga tidak mau diperiksa yang lebih lanjut, dan bahkan tidak mau isolasi dan sebagainya. Ini kategori tidak bergejala atau asimptomatik berbahaya buat komunitas atau masyarakat. Yang kedua adalah yang kritis. Karena yang kritis ini berbahayanya buat dua kelompok. Satu buat dirinya sendiri, karena terancam dengan mortalitas, dan yang kedua buat perawat, saya kedepankan perawat dan dokter yang merawatnya. Jadi dari klasifikasi ini dua yang paling bahaya, yaitu yang tanpa gejala maupun yang kritis. Slide berikut. Karena yang kritis biasanya sudah di ICU dan seringkali sudah pakai ventilator. Di dalam patogenesis kelihatan di sini bagaimana SARS-CoV-2 memperbanyak diri dalam pneumosit kalau di saluran napas ya. Dan umumnya adalah pneumosit tipe 2. Jadi kita tahu ketika pneumosit tipe 2 dimasuki dan kemudian dia bereplikasi dengan hebatnya di dalam situ, maka tentu akan terjadi hiperplasi dari pneumosit tipe 2. Akibatnya adalah produksi dari surfaktan akan berkurang atau paling sedikit terganggu, tapi lama-lama jadi terganggu betul. Terjadilah proses inflamasi karena dia memperbanyak diri begitu banyak, dia keluar dari pneumosit tipe 2 masuk ke rongga alveol, disitulah terjadi inflamasi yang juga merangsang makrofag. Tujuannya untuk memfagositosis SARS-CoV-2, tetapi antara juga melepaskan cytokine. Cytokine ini untuk merangsang masuknya mediator antiinflamasi seperti yang kita kenal seperti interleukin dan sebagainya. Dan itu membutuhkan pintu-pintu masuk atau kebocoran dari vaskuler, kapiler di sekitar alveol. Tetapi begitu hebatnya reaksi ini terjadi, maka yang kejadian berikutnya adalah terjadinya vasokonstriksi, bahkan terjadi penyumbatan, apalagi kalau orang itu perokok, orang itu hipertensi, maka terjadilah sumbatan di dalam aliran vaskuler tadi. Inilah yang kita kenal kenapa orang hipertensi adalah komorbid yang paling besar memungkinkan pasien ini jatuh ke dalam keadaan kritis. Begitu juga pada perokok. Sementara di parunya juga terjadi inflamasi, becek yang begitu banyak, yang begitu hebat, dan cairan itu kaya dengan protein. Jadi protein pun di dalam vaskular juga turun. Yang lain adalah inflamasi ini jadinya bersifat sistemik, dan karena bersifat sistemik dia bisa menyebabkan myokarditis. Myokarditis itu sendiri bagian dari inflamasi sistemik, begitu hebatnya COVID ini. Dan myokarditis itu tentu bisa menyebabkan miopati, dalam hal ini kardiomiopati, dan kalau itu menyebabkan gagal jantung kiri, di sini kematian sudah dekat karena ada odem paru ditambah lagi odem paru kardiogenik. Slide berikut. Nah, lalu kita mulai bicara apa pengobatannya. Pengobatannya jadi waktu di saat pertama itu kelihatan sekali betapa gugupnya kita karena kita tidak sangka akan mengalami pandemi sebegitu hebat, walaupun sebetulnya kita sudah dilatih oleh Tuhan. Kita dikasih avian flu, kita dikasih Ebola, kita dikasih MERS, segala macam. Tapi kita pikir itu hal-hal kecil karena baru bersifat epidemi. Sekarang olimpiadenya datang, yaitu sebuah pandemi, maka pengobatan pun jadi kacau balau hiruk pikuk. Kita ingat bahwa yang pertama kali dikejar orang adalah hidroksiquinolon atau quinolone fosfat ya. Dan itu diberikan karena dianggap dapat bekerja cukup baik walaupun sebetulnya hidroksiquinolon bukan antivirus tetapi antiparasit. Tetapi kerjanya adalah mempengaruhi situasi keseimbangan asam basa sehingga memang rupanya itu cukup berpengaruh sehingga tidak mudah buat si virus melakukan penetrasi ke dalam di reseptor itu. Jadi hidroksiquinolon banyak dipakai, tapi belakangan WHO menyatakan bahwa hati-hati menggunakan hidroksiquinolon karena angka kematian yang disebabkan oleh kejadian kardiak, khususnya oleh karena prolongitnya jadi banyak begitu ya. Banyak lagi obat-obat yang lain dipakai, antara lain tadi adalah favipiravir seperti Avigan yang ditanyakan tadi, juga oseltamivir, dan juga terakhir adalah remdesivir begitu. Ya, slide berikut. Nah, kalau kita lihat begini, maka John Hopkins menyatakan bahwa yang paling banyak ternyata dalam pilihan-pilihan itu sebagai antivirus adalah hidroksikloroquine atau kloroquine sulfat, kemudian lopinavir, ritonavir, kemudian juga oseltamivir yaitu neuroamidase inhibitors, remdesivir juga favipiravir. Sedangkan kita lihat di imunomodulator banyak dipilih kortikosteroid, juga IVIG, dan juga di situ ada tocilizumab selain dari plasma konvalesen. Slide berikut. Kita lihat di situ juga tercatat tadi acalabrutinib sebagai imunomodulator. Nah, kemudian jika kita lihat slide ini, maka kita melihat bahwa mereka semua ahli-ahli itu telah mencoba mencari batasannya. Batasannya adalah dilihat dari perjalanan si virus itu sendiri. Bahwa virus itu ada, kemudian dia naik antara hari ke-7 ke 10, pelan-pelan dia turun, dan pada hari antara 10 ke 14 itu justru antibodi mulai naik, dimulai dari imunoglobulin M, kemudian dari imunoglobulin G, sementara sebetulnya viralnya sendiri pelan-pelan turun begitu. Jadi kalau kita lihat di sini, memang mungkin virusnya akan turun juga, akan mati juga, akan kalah juga sepanjang dia tidak dipicu oleh kedatangan virus-virus lain, yaitu penularan-penularan lain, yaitu pasiennya tidak terus berkontak dengan orang yang lain. Nah, kita lihat di sini bahwa pada fase 1, stage 1 itu gejalanya mungkin ringan seperti batuk, demam, mialgia, dan sebagainya. Dan di stage 2 yaitu mulai terjadi gejala-gejala sedang. Ini yang dikualifikasi sebagai COVID sedang. Tapi yang dua ini bisa kita bagi sebenarnya. 2A ke kiri, 2B ke kanan. 2B itu sebetulnya berat. Kenapa? Karena kemudian dia bisa masuk ke stage 3 yang kanan itu, yaitu ARDS, itu adalah fase kritis. Ya. Ketika dia di fase kritis itu, biasanya temannya adalah ICU dan ventilator, sedangkan yang sedang sampai berat itu, dia bisa menggunakan oksigen dari mulai arus menengah sampai arus tinggi seperti high flow nasal kanul. Dan kita lihat pilihan pengobatannya, maka di situ dipercaya bahwa antivirus sebetulnya bermanfaat sampai kira-kira hari ke-14, 15, 16. Sementara imunomodulator memang bisa dipakai sepanjang waktu, tapi yang pasti adalah adjuvan atau yang selama ini kita kenal sebagai SOC atau standard of care. Slide berikut. Nah, kita kembali lagi ke slide yang tadi. Maka dengan melihat begini kita tahu bahwa kalau mild mungkin pasiennya tidak dirawat, ada di luar. Pasien mulai dirawat ketika dia masuk di moderate, yaitu ketika batuknya agak panjang, mungkin disertai sesak, dan mungkin ada nyeri dada. Ini adalah menunjukkan bahwa dia COVID-nya sudah sampai di paru, kalau ini saluran napas bawah ya, sudah sampai di paru, inilah indikasi rawat, yaitu pneumonia COVID-19, kualifikasi sedang. Jadi kalau kita mengkualifikasi sebagai COVID kualifikasi sedang, berarti kita menentukan dia pneumonia. Saya tambahkan di sini bahwa pada saat ini sudah boleh dibikin foto toraks untuk wanti-wanti berapa luas sebetulnya lesinya. Kalau kita lihat agak luas, segera dilakukan CT scan. Dan untuk apa? Untuk melihat apakah dia sudah akan segera pindah ke severe, karena kalau sudah berarti kita sudah mesti masukkan di ICU. Severe mestinya kita sudah masukkan di perawatan yang intensif, kalaupun itu namanya ICU. Kenapa? Sebentar lagi dia gampang jatuh ke kritis untuk masuk ke ventilator. Tapi kalau di mild kita tidak usah melakukan fototoraks, asal kita kuat betul penalaran klinis kita. Kenapa? Nanti kita berlebihan dan bahkan penyesatan. Dok, fototoraksnya bersih. COVID apa bukan ya? Nah, timbul keraguan seperti itu. Padahal COVID adalah klinis, maka saya menyarankan kalau kita menyatakan kualifikasinya sedang, kita sudah tahu itu kualifikasinya adalah pneumonia COVID, di situ mulai fototoraks. Slide berikut. Ya, dengan melihat itu, maka secara umum sebetulnya di Indonesia inilah pilihan yang dipakai selama ini. Kalau dia ringan dipakai oseltamivir karena dia bisa berobat jalan saja. Kalau dia moderate mulai pilihannya antara oseltamivir atau favipiravir. Kalau severe dia favipiravir atau remdesivir, dan critical remdesivir. Kenapa critical remdesivir saja? Karena pengobatannya diberikan intravena, jadi reaksinya, responsnya lebih cepat gitu. Kenapa favipiravir diberikan pada yang moderate begitu, bukan pada yang ringan? Karena favipiravir ini dosisnya tinggi, perlu evaluasi terutama dari enzim transaminase dan sebagainya. Dan juga favipiravir juga punya tendensi untuk prolong kitik pada gelombang EKG. Slide berikut. Kalau kita melihat begitu, ini ada beberapa keterangan. Di awal mungkin oseltamivir dan dipercaya itu sangat baik, tetapi sayangnya oseltamivir itu sebetulnya tidak bekerja cukup benar, sebetulnya cukup tepat, tidak spesifik, karena dia bekerja pada inhibisi untuk enzim neuroamidase dan tidak ditemukan pada SARS-CoV-2. Bagaimana dengan favipiravir? Memang ada banyak keterangan yang baik, tetapi prolong kitenya ini membuat orang ragu-ragu untuk menggunakannya secara rutin. Sedangkan remdesivir tidak apa-apa dengan risiko apapun, tapi dia digunakan di ICU, jadi dalam pantauan yang cukup kuat. Slide berikut. Nah, kemudian kita masuk ke WHO Solidarity Trial yang diikuti oleh 90 negara, Indonesia termasuk, dan Indonesia diikuti oleh 21 rumah sakit. Saya kebetulan saya ditunjuk jadi Principal Investigator. Ini adalah hasil di bawah, slide berikut. Kalau kita lihat inilah kerja-kerja obat itu tadi di sisi kiri, di slide kiri, tapi di sisi kanan akhirnya pada awal November didapatkan bahwa tidak ada perbedaan yang sangat hebat antara obat-obat yang dijadikan ARMS atau bahan penelitian dari Solidarity Trial tadi. Baik penggunaan interferon yang sekarang mulai banyak diomongin, juga tidak memperlihatkan hal yang beda, juga tentang hidroksiklorokinolon dan juga remdesivir di dalam 28 hari kematian pertama. Tetapi memang remdesivir pada slide yang lain yang tidak saya masukkan di sini, memang lebih cepat untuk memberikan pemulihan di 4-7 hari pertama. Responsnya lebih cepat. Tetapi dalam kematian dia tidak berbeda. Oleh karena itu, di dalam menyatakan mortalitas, sebetulnya belum ada obat antivirus yang spesifik sekali. Slide berikut, dicoba juga obat kalubrutinib yang mau dimulai, tetapi penelitinya menyatakan bahwa peneliti obat yang awalnya menyatakan bahwa ternyata juga ini termasuk imunomodulator tidak juga memperlihatkan hasil yang cukup membahagiakan, sehingga Solidarity Trial memutuskan untuk tidak jadi, batal. Jadi formally discontinue the acalabrutinib study arm. Jadi kita juga kehilangan satu lagi obat-obat ini, walaupun menurut saya justru tidak melihat pada antivirus, saya justru melihat memang pada imunomodulator. Slide berikut. Ya, jadi kita sampai di konklusi mungkin tepat waktu jadinya, yaitu bahwa COVID-19 ini memang penyakit baru, kita semua tahu itu, kita semua gugup, dan karena kita gugup, kita bilang dia penyakit baru kali, begitu kali ya. Jadi kita belum tahu apa yang sebetulnya harus kita lakukan, sudah banyak obat yang dicoba untuk mengatasi penyakit ini, antara lain adalah antiviral, antiinflamasi, dan modalitas-modalitas yang lain kita tahu, misalnya stem cell dipakai, kemudian plasma konvalesen dipakai, dan sebagainya gitu ya. Belum ada antivirus ternyata yang terbukti sangat spesifik kerjanya hanya pada SARS-CoV-2 sebagaimana oseltamivir pada SARS-CoV-1. Dia spesifik karena dia bekerja untuk menginhibisi enzim neuroamidase inhibitor tadi begitu ya. Dan obat-obat ini juga sudah dibuktikan oleh WHO Solidarity Trial. Jadi juga oleh banyak studi-studi yang lain. Studi terpisah satu-satu mungkin ya, tapi ketika dibandingkan rame-rame begitu, obatnya kelihatan bahwa sebetulnya tidak banyak beda antara semua obat, jadi memang tidak spesifik gitu. Lalu, tapi bagaimanapun juga obat-obat tentang antivirus ini masih terus berjalan. Masih ada obatnya, saya belum bisa bilang karena WHO masih minta supaya jangan disampaikan dulu, bahwa masih ada obat antivirus yang memang akan masuk arms penelitian selanjutnya. Tapi ini justru perhatian saya dari awal dulu. Kalau kita melihat dari awal seperti itu, mungkin sebetulnya yang mesti kita pertimbangkan adalah imunomodulator yang kita perkuat. Karena di awal, kalau ingat slide kuning saya tadi, bahwa di awal orang pun melihatnya, ini terjadi imunosupresi, bagaimana membantu itu, dan itu yang kelihatannya akan melawan. Sama dengan kita melihat slide saya yang satu lagi, tadi bahwa kelihatannya, virus pun kelihatannya menurun. Gitu. Jadi ada kemungkinan sebetulnya, kalau dari awal kita menggunakan imunomodulator yang baik, dengan antivirus apapun, mungkin sebetulnya COVID ini tidak perlu jatuh ke kritis, bahkan mungkin tidak ke berat. Demikian yang bisa saya sampaikan, semoga bermanfaat dan kita nanti akan berdiskusi. Terima kasih, Prof. Rita. Thank you to all.
Terima kasih, Prof. Menaldi. Untuk partisipan, kalau ada pertanyaan, langsung ditulis, dimasukkan dalam question and answer. So the next speaker is Dr. Robert Grossberg from United States. I think you are from the Albert Einstein College of Medicine, yes, and associate professor. The topic is about Remdesevir as a new therapy for COVID-19 clinical patient with respiratory distress syndrome. You have 25 minutes for your presentation, please.
Thank you very much. I'm just going to share my screen. You can see that?
It's good.
Okay.
Yeah.
So I want to thank the organizers for inviting me. It's really a great honor to be speaking to this meeting and sharing some news about Remdesevir, an antiviral treatment for COVID-19. So just by way of disclosure, I'll speak a lot about the ACT studies. I'm an investigator for those studies, and I've also received research funding from Gilead, which developed Remdesivir, although the research funding I've received is for HIV work. So just to put, I guess, me in context and the work that I'm doing in context, this figure on the left is a map of New York City, and it's made up of 5 boroughs. I work in the Bronx, which is one of the smaller boroughs by area, but very densely populated and very socioeconomically disadvantaged, and was hit very hard by the COVID-19 pandemic that hit New York in March and April. And on the right, this is a picture of the front entrance to Montefiore Medical Center, where I work. The Bronx is famous for a couple of other things. Yankee Stadium, you may have heard of that, and the Bronx Zoo, which is I believe the largest zoo in the United States. So moving along to the story with regard to COVID-19, this is a snapshot of the Johns Hopkins Global COVID-19 dashboard from about a week ago. Unfortunately, the United States, where I am, is leading in several categories, including confirmed cases and deaths. So not a good situation in the United States. And this is just a figure because I'll be talking about drugs. This is a figure of the life cycle of the SARS-CoV-2 virus, which I think Dr. Menaldi touched on as well. But just the coronavirus is a single-stranded RNA virus. It has these spike proteins on the outside, which form what looks like a crown, leading to the name coronavirus. And it enters the cell via these receptors here, and then this single strand of RNA is uncoated, and then importantly, this enzyme RNA-dependent RNA polymerase is involved in replicating the RNA and then reassembling the progeny virus and releasing them. Remdesivir, the drug I'll talk about mostly, works on this RNA-dependent RNA polymerase. So there are, as you heard about already, I believe, there are a number of drugs that have been mostly repurposed for trials in the treatment of COVID-19. The antiviral drugs that have been, some of them have been, are listed here, including remdesivir. And the other approach to treating COVID-19 has been mostly, in terms of drugs, has been mostly using immunomodulators. Some of the classes that have been used are listed on the right side of this slide. So we know that the disease caused by SARS-CoV-2, which we call COVID-19, is thought of as having three phases. The early infection phase, where there's high levels of viremia and high levels of virus can be found. A pulmonary phase where people may develop respiratory symptoms, and then including pneumonia, and then a hyperinflammatory stage, which is sometimes been called cytokine storm, where the inflammatory response is dysregulated and leads to ARDS and or a number of other conditions. So the optimal place for different medications is at different points in this timeline, but remdesivir, an antiviral treatment, would probably be thought of as working best to address this viral phase before patients move into this hyperinflammatory phase. So to speak a little bit about remdesivir, it's a prodrug of broad-spectrum adenine nucleoside analog, and as I said, it inhibits the RNA-dependent RNA polymerase, which is involved in replicating the viral RNA. This drug was developed for use in hepatitis C. It didn't work, so it sat on a shelf really for many years until it was tried for Ebola virus a number of years ago. Didn't work that well for that either. But it was observed in the lab to have activity against many coronaviruses, and including other novel coronaviruses like the original SARS virus and the Middle Eastern respiratory virus. So in a trial of rhesus macaques, with SARS-CoV-2, it was found that remdesivir was effective in reducing clinical disease and lung damage. So I'm going to speak for a bit about the adaptive COVID-19 treatment trial, or ACT trials, which are sponsored by the National Institute of Health in the US. And these trials are a multi-center, adaptive, randomized, double-blind, placebo-controlled phase 3 trial. So the ACT-1 study, it was a study that looked at patients who were over 18 and hospitalized with COVID-19, who had evidence of lower respiratory tract infection, either radiographic evidence and or a oxygen saturation on room air less than 94%. And patients were randomized to either receive remdesivir 200 milligrams on day 1, 100 milligrams on subsequent days up to 10 days versus placebo. And they were assessed over the course of their hospitalization and up to day 29. The primary endpoint for the ACT studies has been time to recovery by day 29 according to an ordinal scale, the ordinal scale based on severity of illness. And secondary endpoints were looked at as well. And importantly, mortality was not an endpoint for the ACT-1 study. So it was not designed to look at mortality, and that becomes important when we interpret the findings of this study. The major inclusions and exclusions for this study, so patients had to be hospitalized and over 18. They had to have a positive PCR test within 72 hours of randomization and signs and symptoms of a lower respiratory tract infection. And these were the exclusions listed here. The results of the ACT-1 study were published in the New England Journal of Medicine about 1 month ago, and remdesivir was found to be superior to placebo in shortening the time to recovery in adults hospitalized with COVID-19 with lower respiratory tract infection. So the median recovery time in the remdesivir group was 10 days versus 15 days in the placebo group. And these figures on the right, I'll go into in a little bit more detail, show the difference in proportion recovered based on how ill patients were at enrollment. So overall, as I mentioned, the median time to recovery in the remdesivir group was 10 days, as opposed to 15 days in the placebo group. In patients who were not on oxygen, all these patients did very well, or for the most part, the vast majority of these patients did very well. And the difference that remdesivir makes in these patients was harder to observe. In patients on oxygen, but not on high flow oxygen or intubated, you can see that these curves are separating quite a bit. So the proportion recovered in the remdesivir group is significantly greater than the proportion recovered in the placebo group at any time point, according to this curve. And in sicker patients, here you have patients on high flow oxygen or non-invasive mechanical ventilation. You can see that remdesivir seems to be performing better than placebo at day 15, although at day 28, these curves join again. So as time goes on, some of these patients, many of the placebo patients recover anyway, but remdesivir seems to help a significant number of these patients recover faster. And then in patients on mechanical ventilation or ECMO, there seems to be no difference in time to recovery in patients getting remdesivir as compared to placebo. So just to summarize in terms of the efficacy and safety, so the median time to recovery is shown here, 10 days in the remdesivir group, 15 days in the placebo group, and this was highly statistically significant. And this study, as I mentioned, was not designed to look at mortality, but in an analysis of mortality at the 15-day point, remdesivir resulted in a lower mortality rate as compared to placebo. Again, this was not an endpoint designed in the study, so it's difficult to state exactly how significant that finding is. Adverse events were similar in the remdesivir group and the placebo group, with no deaths reported as related to the treatment. In subgroup analyses, you can see that the recovery rate favored remdesivir across the different regions that the study was conducted in, different races, ethnic groups, age, male and female, and symptom duration. And here you can see the differences in the benefit of remdesivir according to patients' baseline severity of illness. So again, this group here, those are patients not who are receiving oxygen but not intubated or on high flow oxygen, seem to benefit the most from remdesivir. Additionally, as you might expect from what we know about the pathogenesis of COVID-19, the benefit was seen to be greatest in patients who were symptomatic for the shortest period of time. So in patients who presented or were enrolled within 6 days of the onset of their symptoms, the hazard ratio for improvement with remdesivir was 1.92 and lower and becoming less statistically significant as patients are sicker longer. So that suggests, as we might expect, that this antiviral treatment works best when given on the earlier side. So I know Dr. Menaldi spoke about the Solidarity trial, and there has been a significant controversy in trying to reconcile the results of Act 1, which were very favorable for remdesivir, with the Solidarity trial, which were somewhat less favorable, to say the least. So the Solidarity trial was a mortality, or is a mortality trial looking at 4 repurposed drugs, as Dr. Menaldi mentioned. And this is a trial that was designed to look at mortality. So from the outset, its design and its goal were different than Act 1. And it's conducted in 405 hospitals in 30 countries, a very large study in which 2,750 were allocated to receive remdesivir. There's no placebo in this study, but the control group are patients who receive no study drug, or standard of care, as the study referred to it. And you can imagine that the standard of care varies from country to country. So when conducting a study in 30 countries, the control group varied quite a bit in the treatment they received. There were 1,253 deaths reported, and the 28 mortality overall was 12%, but close to 40% if patients were on a ventilator at randomization. I think you may have seen these figures. This is looking at mortality for each of the drugs that were used in Solidarity versus the control group or the standard of care group. So you can see, just looking at remdesivir, which is what I'm speaking of mostly this afternoon, these lines are very congruent. There really wasn't any mortality difference in patients who received remdesivir as compared to the controls. There are significant limitations, though, to the Solidarity trial, and I would caution also that the results of this study were reported in a preprint, so have not been peer-reviewed, but we can see that the Solidarity trial was designed with no placebo group and no double blinding. And there was not the rigorous data monitoring that occurred in other clinical trials. There was also variability and unclear methodology in the diagnostic confirmation of infection. And the timing of symptom duration before treatment initiation was not clearly tracked. Additionally, little is known about the baseline severity of illness, and the healthcare capacity status of enrolling sites was unknown, so that the control arm was standard of care, but we don't know a lot about what the standard of care is across these sites. There's a significant amount of missing data that if you look at these curves, you can see that there's a lot of drop-off, and it's not clear why so many patients are lost as the analysis went further in time. And some patients were required to stay in the hospital to complete their 10-day course of remdesivir, which may have added to morbidity as opposed to providing benefit. So if the Cochrane group has an analysis that looks tries to detect the potential for bias in studies, and if you look at Act 1 versus Solidarity, based on these indicators of bias, you can see that Act 1 is a very rigorously designed study that was designed particularly to control for bias. But Solidarity, there are several red flags that indicate a risk of bias, including the randomization process, deviations from the intended interval. So overall, according to this Cochrane analysis, there's a high risk of bias in the Solidarity study. So Act 1 remains the trial with the most rigorous scientific design and conduct to date, with a low risk of bias and high quality evidence. The WHO Solidarity trial, although large and important, has numerous study design and conduct questions, and so has a high risk of bias and considered low quality evidence. So for that reason, this led in part to the FDA, US Food and Drug Administration approval for Remdesivir, and Remdesivir remains the standard of care for hospitalized patients with severe COVID-19 pneumonia. This is just some information about the US FDA's approval and what is in the package insert or the label. So it's indicated for the treatment of hospitalized patients with suspected COVID-19 and can be started anytime after symptom onset, although we know that it probably works best earlier it's given. Patients should have their estimated GFR checked and hepatic laboratory testing prior to starting, and these should be monitored, as should prothrombin time. But as I mentioned, this drug is very well tolerated. We do not see a lot of toxicity. The drug is given over 30 to 120 minutes, and the usual dose is a loading dose of 200 on day 1 and 100 milligrams on days 2 through 10 for very sick patients, but almost everyone else usually we treat for 5 days, and I'll get into that a little bit. The drug is contraindicated in patients with a history of hypersensitivity reactions to remdesivir, not recommended for patients with an estimated GFR less than 30, although that is being studied to see if this can be estimated GFR can be lowered. And there are some warnings on the label about infusion-related reactions and transaminase elevations, both of which are very rare. There's little known about certain special populations. Remdesivir has been given to many pregnant women, although there's no adequate or well-controlled studies. It appears to be well tolerated and not teratogenic. And these other categories are areas where additional study is needed. There is guidance on pediatric dosing, which I show here. There's ample experience using this drug in children, including infants, but patients over 28 days old should have their eGFR monitored prior and during treatment. I wanted just to mention another set of studies with remdesivir. These studies were sponsored by Gilead, the SIMPLE studies, and they're similar. There's one study that is in severely ill patients and the other in moderately ill patients. So this was a multi-center randomized open label phase 3 trial in patients with SARS-CoV-2 and varying levels of illness. So in the severe study, patients had to have an SpO2 less than 94% on room air. And these patients were randomized to either receive remdesivir for 5 days or 10 days. And the study looked at their clinical status at day 14. And the major finding is that there was similar clinical improvement in patients with severe COVID-19 in the 5-day group as compared to the 10-day group. So that suggests that for most patients, 5 days is enough. For patients receiving mechanical ventilation or on ECMO, there may be a rationale for giving 10 days, mostly because these patients are sick for a long time. But even that's not clear. 5 days may be enough in that setting as well. In the moderate arm of this study, patients were at baseline had an oxygen saturation over 94%, and they were randomized to receive 5 days of remdesivir versus 10 days versus no remdesivir, or the standard of care. And in this study also, patients receiving 5 days of remdesivir benefited compared to standard of care, and there was no difference reported in improvement in 5 days versus 10 days. So this led to the FDA labelings indicating the drug for 5 days unless patients are on mechanical ventilation or ECMO. This study also looked at the use of hydroxychloroquine, which at the time was being widely used in the US and in other countries. And hydroxychloroquine, when added to remdesivir, there was really no benefit. These are, the blue line here is without hydroxychloroquine, and the orange line is with hydroxychloroquine. So in fact, it may have performed worse. Remdesivir, as I mentioned, is approved by the FDA in the US for use. It's also been approved for use in a number of other countries, which I list here, and many others as well. Just to get back to the ACT trial, or the Adaptive COVID-19 Treatment Trial. So this study was designed from the outset as an adaptive trial. So you can see here the different stages of ACT so far. I spoke mostly about ACT 1, which was remdesivir versus placebo, which led to remdesivir being now part of the standard of care. ACT 2 was a study of remdesivir plus or minus baricitinib. Baricitinib is a JAK inhibitor, a Janus kinase inhibitor. So this is addressing the it's an immunomodulator, so addressing this hyperinflammatory state. I'll get to a little bit about the results of that study in a minute. Remdesivir, so ACT 3, which recently closed, is a study of remdesivir plus interferon beta, this given subcutaneously. And the stages will continue until the pandemic ends, so there is preparation underway to start ACT 4 now. The Act 2 results have not been published, but via a press release by Eli Lilly, who makes baricitinib, they did report a shortened time to recovery by 1 day in the baricitinib group compared to placebo, and clinical improvement for more patients by day 15 in those that received the baricitinib. This publication should come out in the next 1 to 2 weeks. It's under review. Act 3, which you may recall was remdesivir plus or minus interferon beta 1A. This study is fully enrolled as of last week with over 900 subjects. The subjects are still in follow-up, so we don't have any data to report on that. And with that, I'll close. I thank you very much for your attention, and I thank the organizers for inviting me, and I look forward to the discussion.
Thank you, Dr. Grossberg. And now we proceed to the question and answer. And I start with Dr. Grossberg. There's maybe 4 or 5 questions directly to you. And I just read it and you have the time to answer them. First is from Dr. Nafi, I think. Dr. Nafi asked that, do you have any data about what will be the result if we use remdesivir only for 5 days? The first question. And another question for you, if there's no significant difference between remdesivir and placebo in patients with mechanical ventilation or ECMO, why we still use for patients with that situation? Okay.
Okay.
Yeah.
So with the first question, so there is data that 5 days of remdesivir is as good as 10 days in remdesivir in most patients. So that data comes from the SIMPLE trial that I showed. So in virtually all patients, 5 days did as well as 10. So that's the standard now, at least in the US, is to use 5 days of remdesivir. There's, for not very good reasons, patients who are critically ill and not recovered, the duration is extended to 10 often, but there's no demonstrated benefit to giving more than 5 days. And with regard to the second question, can you remind me again what that was?
If there's no significant difference between remdesivir and placebo in patient with mechanical ventilation or ECMO, why we should still use it for patient with that situation? What do you think?
That's a good question. So in all of these studies, the patients who are on mechanical ventilation or ECMO are, obviously they're very ill, they're very complicated. They often have significant other complications like, multi-organ failure other than their lungs. So it's very difficult to draw conclusions about the benefit of remdesivir in that group unless you had a extremely large study. So I think it's not, I don't think you can necessarily draw conclusions either way. I think in patients who present early and are intubated or put on ECMO early in the course of their illness, which isn't so common. Usually those patients are later in the course of their illness. But early in the course of the illness, I think you can it makes sense that remdesivir would likely benefit. On the other hand, it's harder to make that case in patients who are presenting later. The drug is well tolerated, although costly. So generally, the only downside that we see is cost, which may be an important consideration. But on the other hand, in these patients who are so sick, there's little to lose, and there's at least the potential for benefit, although that was not measured. We can't report that as a finding of these studies. We do a lot of things in the ICU. Well, you all probably do more of it than I do. I'm an infectious disease doctor, but critical care doctors, I think it's safe to say that many things are done in the ICU that haven't been proven to work, but there's a suggestion that they may work.
Yes, okay. And I think the last question for you, and then we will ask Professor Menaldi. The last question, actually there's so many questions, but I just choose. Are there any concern about combining remdesivir with immunomodulator such as tocilizumab or dexamethasone? Any concern about combining them?
In general, I would say no. In fact, combining remdesivir with an immunomodulator may be exactly the correct approach to treating COVID-19, especially severe disease. So that was the hypothesis for the Act 2 study, which looked at remdesivir plus or minus baricitinib, which is a JAK inhibitor and immunomodulator. And dexamethasone may be part of the Act 4 study. I can't say either way right now, but the use of an immunomodulator is it's a different approach, and it's one that makes sense to combine with the antiviral approach. So I wouldn't be concerned at all about using them together.
Okay. So I will ask Dr. Prof. Menaldi comment. Do you have any comment about this question? Because you also have so many questions, but just give comment for the question and the comment of Dr. Grosberg. Do you have any comment?
About the use of immunomodulator?
Maybe, yes, the last one. Yeah.
Yeah, of course. Of course, for the viral diseases, we have to use the antivirals. The choice is the antivirals first. But don't forget that in COVID, to my opinion, we don't have yet a specific antiviral that is really significant different compared to the other antiviral. So anyhow, we see that the inflammation is can be so severe, so that it also needs a special treatment for that. So combination of the antiviral and an immunomodulator, I think it is to be concerned, especially when the patient is being hospitalized. It is not when the patient is as an outpatient clinic. It's okay in the mild case that the patient will be asked just to make a self-isolation, not in the hospital. It's okay that we just use the modality of the antiviral only. But in patients who are hospitalized, to my opinion, I will consider to also give in the combination with the immunomodulator. Thank you.
Thank you, Prof. Menaldi. And there's also a question special for you. I will read it in Indonesia. Mohon penjelasan mengenai hubungan antara infeksi virus yang self-limiting disease dengan kerja obat antiviral. Dan yang kedua karena terkait Avigan, Prof. Apakah yang harus diperhatikan saat memberikan Avigan? kepada pasien dan berapa lama? Pertanyaan dosis untuk anak berapa? Tadi belum ada ya, Prof, di dosis anak untuk di presentasinya.
Tidak, jujur saya
Prof.
tidak punya pengalaman untuk anak. Jadi saya tidak berani jawab kalau untuk anak gitu ya.
Ya.
Saya berani untuk orang yang tua-tua aja. Jadi tadi apa tadi pertanyaannya?
Apa hubungan antara
ini ya,
infeksi virus?
Okay.
Ya.
Secara umum, infeksi virus itu dikenal sebagai penyakit yang self-limiting disease. Jadi kalau kita ingat tentang influenza misalnya, influenza viral influenza, kan kita tidak minum obat. Istirahat saja, lalu kita akan kuat kembali. Tapi jangan lupa, itu adalah pada virus-virus yang kita sudah kenal, yang kita sudah hidup bersamanya. Bahkan misalnya dengan virus H5N1 yang dulu kita takuti betul ketika flu burung, ingat dulu avian influenza, sekarang kita tidak takut, kita tidak periksa, kita hidup bersamanya begitu. Nanti ada saatnya virus yang SARS-CoV-2 ini barangkali kita juga akan hidup damai dengannya itu. Ya. Ada vaksinasi nanti, ada segala macam. Jadi kita mungkin akan hidup damai dengan mereka. Tetapi sekarang ini, maka walaupun infeksi virus umumnya dikenal sebagai self-limiting disease, tetap pada COVID ini kita harus tekan dulu. Kenapa? Tadi saya sampaikan pada waktu penyampaian saya bahwa ini SARS-CoV-2 ini karena badan kita belum kenal, maka penularannya sangat hebat dan cepat dan juga menyebabkan kematian begitu tinggi. Kalau kita bisa tanya pada Prof. Grosberg, kita tanya berapa angka kematian di negara Anda? Tinggi sekali di Amerika. Gitu ya. Kalau di negara kita tidak begitu tinggi, alhamdulillah saya juga masih mencari tahu apa sebabnya begitu. Tetapi di Amerika, di Italia itu sampai hancur-hancuran mereka itu. Apalagi di Cina dulu gitu. Jadi pada COVID, saya tetap berpendapat antivirus mesti masuk. Mesti masuk. Kalaupun dia berobat jalan, kita tetap mesti mengupayakan memberikan obat antivirus, tapi dengan catatan pasiennya diminta isolasi mandiri. Itu apa tuh sebetulnya? Sebetulnya kan kita minta supaya pasiennya memulihkan sistem imunnya karena dia tidak terpajan yang lain-lain, dia tidak kelelahan, dia tidak boleh dalam keadaan tegang kalau dia ke kantor atau dalam perjalanan, begitu. Itu satu. Yang kedua, pertanyaan tentang Avigan atau favipiravir. Favipiravir ini dikaitkan dengan kecepatannya untuk menaikkan enzim transaminase, gitu ya. Jadi kalau kita mau memberikan favipiravir, memang sebaiknya kita memeriksa SGOT, SGPT, dan yang selanjutnya adalah sebetulnya kita mestinya tahu bagaimana gambaran EKG atau riwayat jantung pada pasien ini. Karena favipiravir salah satu yang ditakutkan adalah juga mempunyai kemungkinan membuat prolongite tadi. Gitu. Itu sebabnya favipiravir lebih banyak dipilih untuk diberikan pada waktu orang dirawat tapi cukup tenang gitu. Tidak dalam keadaan yang, jadi artinya kalau kita bicara WHO klasifikasi sedang gitu. Tapi kalau klasifikasi berat, umumnya kita tidak lagi berpikir tentang favipiravir tapi kita berpikir soal remdesivir. Kalau ditanya kenapa? Karena remdesivir diberikan intravena. Jadi mestinya kerjanya lebih cepat begitu. Nah, dan favipiravir kalau dia berobat jalan pun kita berani berikan, maka berikanlah yang paling aman itu kalau orangnya tidak punya riwayat jantung adalah pada orang-orang di bawah usia 45 tahun. Relatif kita akan lebih aman di situ gitu. Tapi kalau orangnya sudah usia 50 tahun ke atas, hati-hati memberikan favipiravir pada waktu kita menentukan pasiennya berobat jalan. Karena kalau dia prolongite segala macam, dia tidak tahu. Nah, udah pernah mencoba prolongite belum? Itu biasanya dimulai dengan takikardi, dia mulai berasa dengan berdebar-debar begitu. Yang berdebar-debar yang kita anggap sebagai takikardi biasa. Tapi sebetulnya itu adalah kemungkinan efek dari itu. Nah, yang selanjutnya adalah satu catatan, kinolon juga bisa memperkuat prolongite tadi. Oleh karena kalau kita memberikan obat antivirus seperti favipiravir tadi, saya menganjurkan tidak memberikan azitromisin atau kinolon. Jadi tidak memberikan macrolide atau kinolon. Kenapa? Karena tanpa kita sadar dia di rumah, tapi dia sebetulnya mengalami nanti prolongite yang kita tidak bisa kontrol. Makasih.
Oke. So, terima kasih Prof. Menaldi. And the last question, because the time we have only 5 minutes more. I hope that both of you can just answer this. What is the standard care of patient in moderate phase? I mean in Indonesia, Harapan, and in US. The standard care of patient in moderate phase in your place. First, Dr. Robert, please.
So if you're speaking about moderate phase, meaning in the hospital, but not on oxygen, there's some controversy about in the U.S. about using remdesivir in that setting. So it depends a little bit on the risk factors that the patient may have for progression. Most of the guidelines in the U.S. leave it as a vague option in patients who are not on oxygen but are in the hospital, that remdesivir is not, forgive me, I'm not remembering the exact wording, but it's not recommended, but is an option. In patients on oxygen, even nasal cannula, remdesivir would be the standard of care. There is a question about its use outside of the hospital, where there's no indication in the labeling to use remdesivir, and because it's intravenous, that option would be limited anyway. And then there's also a question about patients who present with non-respiratory illness from COVID-19. So as you know, patients can present with COVID-19 disease other than pneumonia, like encephalopathy or myocarditis or thromboembolism, things like that. So we don't know what the benefit of remdesivir might be in that situation, but if patients present early, it may be a benefit and is likely of no harm. But again, the drug isn't indicated for use in that situation, but that's a question as well of what it might do for patients who present with non-pulmonary presentations of COVID-19.
Okay, Dr. Grosberg. And how do you think, Professor Menaldi?
Yeah, I agree with Professor Grosberg that in the classification of moderate COVID, in Indonesia we choose first the favipiravir, yeah, favipiravir, but still we have to be very cautious about the possibility that the patient will fall in a very quick moment to become in a severe or eventually the critical. In that condition, we can start with remdesivir, but as long as, like Professor Grosberg already told us, that if the patient is not using the oxygen, the patient is quite in in the steady state, so we can use the favipiravir, but not in the severe condition, the severe qualification of WHO. We should start directly with the remdesivir because it is intravenously given, so the direct action, we hope that the direct action will give a good result for the patient. But if the patient not in the respiratory symptoms, but with neurological symptoms, we have to consider to give remdesivir first, even it's not in the ICU. Since that the intravenous way of giving, we hope that it will be more worse for the patient with the symptoms of neurological symptoms. Thank you.
Terima kasih, Prof. Menaldi. So I think we have to just stop with this question and answer because of the time. We have a closing ceremony. But I think the participant can just decide what will they do, what we do, depend on the situation, and just consider what Dr. Gross and Prof. Menaldi just mentioned. Thank you very much for both of the speakers, and I will just give back to the MC. Again, thank you, Prof. Menaldi, and thank you, Professor Grosberg.
Thank you, Professor Rita, and thank you, Professor Grosberg.
Back to the MC, Dr. Marisa, yes, please.
Oke, terima kasih. kepada Profesor Dr. Nancy Margarita Rehatta, SPHN, KNA, KMN selaku moderator. Terima kasih juga kepada Profesor Dr. H. Menaldi Rasmin, SPPK, FCCP, FISR sebagai pembicara. And thanks to our speaker, Robert M. Grossberg, MD. Dan tidak lupa juga kami ucapkan terima kasih kepada mitra sponsor Dexa Medica yang telah mensupport sesi ini. Untuk para peserta, PIB ke-17 Perdatin, sertifikat Simpo dapat didownload pada akhir rangkaian acara PIB 17 Perdatin. Jangan beranjak dulu, karena inilah saat yang paling ditunggu-tunggu. Pembagian door prize berupa 5 unit termogan barrier FT90, 5 unit barrier pulse oximeter PO30, 1 box masker Draeger N95 Explore 1350, 2 unit Philips Pro Blend 4, 2 unit Cosmos blender kaca, dan grand prize 2 unit sepeda gunung. Jangan kemana-mana dulu.